Good afternoon, everybody. We still have many more folks to join, so just bear with us, give us a few minutes, and then we'll get started. If you are a committee member, if you would put your name in the chat. If you're a committee member on the phone, unmute and let us know that you are here. We should be getting started here in just a few minutes as a few more folks from the committee are joining. Thank you. Again, good afternoon, everybody. For those who have just joined us, we are still waiting for a few more folks to join. We're also still waiting for Jessie Mandel as well, who is the chair. She should be coming on in just a moment. So if you are a committee member, if you would, please put your name in the chat. If you're a committee member who is on the phone, please unmute yourself and let us know that you are here. And we should be getting started here in just a moment. Thank you.
This is Kim Danzy. I'm a committee member who's on the phone.
Great. Thanks, Kim, for letting us know you're here. Thanks.
Thank you.
Sharon, I'm just restarting my computer, so you'll see me rejoin in just a minute.
Sounds good. Thanks, Jessie.
Yeah. Will you let me know if you have quorum?
I certainly will. Just give me a moment. We still have many more folks joining. Okay, Jessie, we do have a quorum, so you can get started whenever you are ready. Thank you.
Great. Okay. Thank you so much. Yes, just give me 1 second and I'll start the meeting. I'm just joining from my laptop now, so you'll see me come back in. So I'll be here in just a minute.
All right. Thank you. Sorry about that. Welcome, everybody, to the April, in case you're getting confused what month it is, to the April Medicaid Advisory Committee. It's great to see many of you and also to have seen many of you from the previous CHIP Advisory Committee. So let's get started. So just a reminder, as always, we have made the decision to have this meeting held virtually until further notice. We had started to have some conversation at the CHIPAC about if that will change, but until further notice, this meeting will continue to be held virtually. So we will continue to be over Google Meet. And we also need to approve the minutes. We did not approve the January meeting minutes, so we're going to be looking at the March and the January meeting minutes to approve. So hopefully committee members have had a chance to review them. If not, just take a second. And when someone is ready, I think we can take a motion to approve both at the same time. If I'm wrong, please let me know. If I'm like breaking Robert's rules or something, but I think we can do both at the same time, unless there are any changes.
Jesse, this is Brian. I read the January, but not the March. So I could move approval on the January, but I don't know if somebody has done them both. Maybe it's best they do it.
This is Kim Dancy. I've read both, so I'll move that we approve the minutes.
Oh, good.
Great. All right. Can I get a second or somebody to, second the motion? I do know that my name is spelled wrong. I saw that, but I figure for the state of the minutes, we can just move forward. That's not a show-stopping error.
Jennifer Lloyd, I second the approval.
Awesome. Thank you, Jennifer. That was a very fitting motion to make because next on the agenda is something I would prefer to just skip over, but you are terming off the MAC, which is very sad. You've just been tremendous, and we really appreciate all of your service. So thank you for making that motion. I guess this is not your last MAC, so you can, I think that you'll be up in May. Is that correct? May is yours. So you will.
No. So Jesse, no. So her appointment ends at the end of April. So this one is actually her last MAC.
Okay.
Yeah, sad. Thanks, Jennifer, for your service to the MAC.
Yeah.
Thank you all. And I'll still be at the MAC. I'll just be sitting quietly or not so quietly in the background. Thank you.
Thank you, Jennifer. Yes, please don't be quiet. Thank you so much, everybody. And that's also just something I wanted to remind everyone that this is an open meeting. So please feel free to make comments, ask questions. Committee members and members of the public alike, you can put them in the chat or unmute yourself, however you feel comfortable. But please remember that that this is a forum where everybody can ask questions or raise up concerns. So with that sad news, I was actually thinking maybe I would just have skipped over that part about Jennifer Lloyd leaving, but I can't do that. So we do have some open seats as well. Sharon, do you want to update that, or would you prefer to wait until the next meeting in May?
Yeah, so we obviously have Jennifer Lloyd's. We're accepting nomination for Jennifer's appointment, a provider representative for the community health centers. We also have a provider representative for the pharmacy group open as well. And last, we have a member appointment open. So we do have 3 vacancies currently on the MAC. So if you have any nominations, please send me their contact information, or if you are interested in joining, please send me an email. My email is on the bottom of the agenda. So thank you.
Thanks, Sharon. And we are also still, Louise had suggested, or it come up to the as a suggestion to have a one-pager to share around to get more people involved. That is still going through the works. We'll probably have that by the May meeting. So, oh, thanks, Sharon. We're just finalizing that, so we can talk a little bit more about this one-pager and the open seats at the May meeting as well. And we can share that out as soon as it's ready. Great, thanks. Okay. Well, with that, Stephanie, I see you're here. I'll turn the time over to you.
Thank you. To introduce myself to those of you who don't know me, I am the Assistant Attorney General who is assigned to represent the Utah Medicaid program in certain areas. And one of those areas is to provide training under the Open and Publics Meeting Act. All of you should have received a copy of the summary handout. It's part of the meeting minutes and was part of the agenda. But we can get started. And we'll go through this somewhat quickly. Please interrupt me if you have some questions. A lot of you already know how this works, but to start with, Utah Code Section 52-4-104 requires that members of a public body be trained annually on the requirements of the Open and Publics Meeting Act. It has been determined that the MAC is a public body as defined by the Open Meetings Act and therefore is subject to the requirements of the Act. The stated goal of the Open and Public Meetings Act was to ensure that the state, its agencies, and its political subdivisions take their actions openly and conduct their deliberations openly as they go about the state's business. One of the things that's required is that the MAC provide notice and agendas to the general public. So as a public body, the MAC is required to provide a public notice of a meeting at least 24 hours before the meeting. The notice must include the date, time, and place, include an agenda that specifies the topics you will consider. The notice must be posted on the Utah Public Notice website at the location along with the location of the meeting, and it should be provided to a newspaper or a local media correspondent as well. You may discuss an item raised by the public that is not listed on the agenda, but you may not take any final action on the item at the meeting if it is not on the agenda. Electronic meetings. Let's talk about that for a minute. As any questions so far, I should say, of the board? Okay, we will continue going on. Electronic meetings is required by the Act. The MAC follows the administrative rule made by the Department of Health in R380-42 in conducting an open meeting electronically. Per this administrative rule, if the MAC meets electronically, the designated anchor location, which is the physical location for the meeting, has been the Cannon Building, located at 288 North, 1460 West in Salt Lake City, Utah. However, a quorum is not required to be present at that anchor location if the meeting is being conducted electronically. Also, this same administrative rule allows the person presiding at the MAC to restrict the number of separate connections for members of the public body that are allowed for the electronic meeting based on available equipment capability. The Department of Health continues to work to make sure that as the capability is the same as to reach all members of the public who want to attend this particular meeting. Minutes and recordings. The MAC must keep written meetings and a recording of all meetings unless the meeting is a site visit or a traveling tour where no vote or action is taken. If the MAC takes comments from the public who are not members of the MAC during the meeting, the commenter must first be recognized by the presiding officer. Therefore, comments in the box are not recognized, in the message box are not recognized unless the commenter is first recognized by the presiding officer. If that happens, the commenter's name and the substance of their comments in brief must be included in the meeting minutes. So comments in the chat box are not considered by definition under the statute a comment that will be included in the meeting minutes or recognized. The recording of the open portion of this meeting must be posted on the Utah Public Notice website within 3 business days after the meeting. The MAC must make a draft of the minutes available to the public within 30 days after the meeting. Meaning, of course, that the minutes that were adopted today for past meetings need to be made available to the public on the website within 30 days. The approved minutes and within 3 days, the approved minutes and any public material drafted at this meeting must be posted on the Utah Public Notice website within 3 days after their approval. That's your 3-day time period from today. Closed meetings. You may close a meeting by a 2/3 vote of the quorum present at the meeting for discussion on the following: a person's character, competence, or health, pending or imminent litigation, matters related to the sale or acquisition of real property, the deployment of security personnel, devices, or systems, or the deliberation and decision-making process involving the procurement. I think all of these subject matters are very rare, if ever occur before the MAC, but you are statutorily you are statutorily authorized to close a meeting to discuss these kinds of matters. If you vote to close a meeting, you must announce and record in the meeting minutes the reasons for closing the meeting. You may not take a vote in a closed meeting except to vote to end the closed portion of the meeting and return to an open meeting. Again, given the nature of this committee as advisory, I don't foresee, and I may be wrong, that you will need to use the closed meeting authorization in the statute at this point. Emergency meetings. You may hold an emergency meeting, which does not require the 24-hour notice we talked about earlier, if unforeseen circumstances arise that require you to consider matters of an emergency or urgent nature. However, you must first attempt to notify all MAC members and seek approval of a majority of the MAC members in order to hold an emergency meeting. Again, as an advisory board, I don't know if you do or have ever had a reason to conduct an emergency meeting. One of the things that we require to do in this annual training is to also update you on any changes to the Open and Public Meetings Act, and there have been some in this past 2022 legislative session. Pursuant to House Bill 22 from the Utah 2022 General Legislative Session, this committee must do the following. Be aware of and follow the department rule that we discussed before, the rule change that will establish the conditions under which a remote member is included in calculating a quorum for an electronic meetings held after December 21, 2022. The department will go ahead and amend its rule to include those when that may be allowed. You also must determine whether you are, after determining whether you are statutorily authorized to allow a MAC member to act by proxy, you must establish the conditions under which that member may vote or take other action by a proxy. Otherwise, if the MAC is conducting an electronic meeting, it may not allow a member to vote or act by proxy. And finally, except for a unanimous vote, you must take a vote by roll call in an electronic meeting. That is something new. And those are all, that's the training, and those are the updates from the 2022 legislative session. Any questions? If not, then I will turn my time back over to Jesse, and I'll see you all again next year.
Thank you, Stephanie. Great. Well, thanks. Any other questions from anybody about that? I know there have been some questions about the meeting minutes in the past, but I think we can follow up with you just regard to how they're written up in this committee. So
I am available to advise the department and the committee for any legal questions that they may have. You may have.
Great, thank you so much. All right. With that, oh, I'm sorry, I went ahead. I was off. I'm looking at the agenda now that we were going to talk about the flyer, so we can go back to it. My apologies, everyone, but this is the flyer that we are developing. Do we know this, or Sharon or Jen, do you know the status of it? Okay. Great. Do you want to share a little bit?
Sure. I'm happy to speak to the flyer. Jesse.
And or if you know if it's been approved too.
Yes, it has been.
Okay.
Thank you. Go ahead if you want to show. I guess Sharon has it up if you want to go through it.
Yeah, sure. So this this is the flyer that I gave a sneak preview of before. This is the flyer that we have put together to share information about the MAC overall that hopefully we can use to give information to individuals that might be interested in joining the MAC that don't know a lot about what it is. So we've included some information about that, and this will be available on the MAC website. And if you have any questions, we'll share. Well, I know it's been something that has been a long time coming, but it's really more of just an overview before someone joins. So it's not going to have all the nitty-gritty details about the ins and outs of how the MAC functions. This isn't like a bylaw update. Really, it's just a way to engage people that might be interested in joining but want to learn more. And hopefully this can be something that committee members and members of the public disseminate with people that you think might be good fits for the MAC, or you think should just consider it, or have some time and availability, or just have a great advocacy voice that they would like to be part of the MAC. Please use this document, and if you have any questions or suggestions about it, let us know too. But we will be getting this out to people, and we can, if you even want paper copies, I'm sure we can even do that in this day and age. So yeah, any other thoughts from members of the committee? Any questions about this document? Hopefully this will be a way to help get the word out about what the committee is, since I think it can sometimes be a little confusing to people.
Yeah, Jesse, I just wanted to just jump in and add that this is it's sent to anybody, but this was designed so that Medicaid members can really, and their family members can really, it was kind of designed with them in mind. So just wanted to make sure to highlight that this is great to send to, especially to Medicaid members that may want to be involved.
Yeah, thanks for that. We did talk about maybe doing like a provider overview for members who sit in the provider seats. I think that's less necessary at this time, but it could be something we work on in the past. I'm sorry, in the future. Okay. Great. Anything else to say about the flyer? All right. With that, are there any other member updates or information or questions that people want to flag this time? Okay. All right. Well, any from members of the public, any Medicaid related questions or concerns? Okay, great. Well, if anything comes up after this time, feel free to put it in the chat. And we're back on track. Sorry for my agenda hiccup, with Jeff to share a little bit about the unwinding plan.
Wonderful. Well, for the first time in MAC history for me, we're going to actually have a nice slideshow to show you today. So let me see if I can get that presenting correctly here. And here we go. The slideshow from today and plan narrative were given out just actually earlier today. So you should have that in your inboxes if you're a member of the MAC and receive those email notices. So let's start. We are probably close to the throes of returning Medicaid eligibility to normal operations when the public health emergency ends, which of course we are calling the unwinding. Michael Hales asked me who gets to name these things, and the answer is I don't know. But the overall, most states are calling this the unwinding process. So let's jump in. All right, well, today we're going to give you an overview of what our plan is for unwinding the Medicaid eligibility and returning life back to normal, what it was 26 months ago. We have some objectives, though, and one of those is to make sure we have a very smooth member transition. To that end, we want to make sure we're being very clear with our communication to members, to those that have interest, to advocates, et cetera, and this group, of course, that we have good data transparency so you can see what's happening and where folks going, that kind of thing. and robust planning, of course. And the planning efforts, and I'm sorry if this feels like a Jumanji game. I feel like I'm pulling you all into the world of unwinding, but the planning efforts for me have been going on since last August and continue to this very day. I think half my meetings start with PHE unwinding something or other. Let's jump in. So let me define our problem a little bit here today, which is that we all are aware that COVID-19 hit our country and it hit the world back in 2020. Very quickly, there were a couple laws that passed, and as a surprise to Medicaid agencies across the country, we were all required to now have this new provision, which is called continuous coverage of Medicaid, that we implemented very quickly. And we also did this at the time with our CHIP program, which has since been unwound or those provisions went away back in April last year. But now for 26 months and counting, Utah has kept all Medicaid cases open. So once someone qualifies for Medicaid, their case remains open until the end of the public health emergency. We don't know when the public health emergency ends, and that's the tricky part here. But it is time to at least start to share our plans of what happens when and if. And we'll walk through a little bit of a timeline in just a moment. All right. And please, if there are questions, you're welcome to raise your hand at any point in time. There are 3 reasons that we're allowed to close cases. So if you do see a Medicaid case closing, it is likely for one of these 3 occurrences, which is the member either passes away, the member moves out of state and we've verified and validated that, or if a member requests that their case be closed. That one doesn't happen an awful lot, but it does occur from time to time. We have been busy. There have been a lot of what we're terming pre-unwinding activities going on in the background. A lot of that is just simply trying to get our arms around the work and understand how many people we're talking about, to figure out what our data is telling us, and again, plan for what this looks like as we move forward. We have sent out several messages, and this group is one that we've talked to a few times about this as well, certainly about keeping address and contact information up to date with Workforce Services, either through the health department with us or through Workforce Services directly. We've actually added that capability to our, many people know about our health program representatives. They do a fantastic job of educating clients on which health plan to select. They also can issue new Medicaid cards and can update your address directly into the system, which has been fantastic. We've worked with an idea for Workforce Services. They have a vendor right now with Equifax. If you've heard of Equifax, they're one of the big 3, Experian, TransUnion, but they're one of the big 3. And this was interesting to us. They actually helped the United States Postal Service keep their addresses up to date, which we did not know. That's fantastic information. So we have a contract with them already, and we are right now trying to get a contract in place where we can match many of our folks that we have on Medicaid with their data. They're tied in not just to people getting credit reports, but also with different utility companies, et cetera, around the state. So they're going to provide us with the last 2 addresses that a person has, and we can then compare that to our records to make sure that we've got an updated address. That's kind of a newer thing. We've shared closure lists with health plans. This is new for us as well. We've just started doing so. Right now, those are just CHIP children that are closing. So we're able to share the CHIP children that have, we actually share 2 reports. One is to say, here is who's coming up for renewal next month. And near the end of that month, we now share a report that says, here is who is going to be closed at the end of the month because we haven't heard from them. Or if they're moving to the exchange, we can actually parse that out so they can see that as well. So those are some of the new activities that we're doing already in preparation to get us prepared for what's going to happen as the unwinding occurs. We've been talking quite a bit with Workforce Services about transparent reporting. And today, for the first time ever, you guys are going to be the first ones to see an actual demo of our proposed dashboard. So I'm excited to show you that at the end of the presentation, which is the next bullet point there of this unwinding dashboard. And then finally, as far as planning goes, we have now shared a plan officially with you. You've seen our plan narrative. There are more documents that go behind that. There's some very technical documents that if anyone is excited to, if you're not sleeping well, we can share those with you at any time. We're actually filling those out as we go to try and talk in the technical eligibility speak to our partners at CMS so they can understand what the state of Utah is going to be doing. And recently, CMS reached out to the state of Utah, which we found that this was a fun moment for us. We learned that we are one of 10 states that they're really interested in watching. The reason they're interested in Utah is that we have done a very good job of keeping cases open. That was a nice pat on the back that we weren't necessarily expecting to get. But what that means is we've actually grown our Medicaid program. And again, we've had the adult expansion and other characteristics are obviously occurring at any given time. But our Medicaid percentage-wise has grown more than other states. So that was interesting to us. Like I mentioned earlier, we've now have the ability, we've flagged or marked or indicated on cases that are being held open so we can see what the workload is in front of us. And this is one of many, many meetings that we've had together. Here's the first timeline. This is kind of fun to see with some real dates on it now. It has its first real date. On April 16th, just a week ago, we heard that the PHE was extended for a new 90-day period through about July 15th. That is, we believe, could be the last extension we see on the public health emergency. This is the federal public health emergency as opposed to the state public health emergency declaration. If that is indeed true, that would mean that we would expect to get 60-day notification from Health and Human Services. That's been promised to be given to all states before the public health emergency ends. So I'm focused right here. That 60-day notification would trigger a series of events. Within the next 30 days, we would be sharing baseline eligibility information with CMS. The state would submit what's called a renewal distribution plan. In English, that means who are you going to look at and what's the order of the people you're going to look at. And we'll show you a little bit more about that in a moment. And if we're ready, DWS can start reviewing cases that about 30 days before. There's a catch to that, and I'll show that in a moment as well. The COVID-19 group that we cover in our state, not every state covered this group. Our state chose to cover a group called the COVID-19. It was the testing group. It's now called the coverage group or the uninsured group. We are actually right now trying to add benefits to that group where we're able to pay for vaccinations. So we're excited to be able to make that change here shortly, which will be retroactive, I believe, back to March. That group, however, does end on the day that the PHE ends. So if the PHE were to end on July 15th, for example, this group's coverage also ends at that time. And that's a unique group in that they don't actually go through a full renewal at that point in time. Because of that, we're trying to communicate with those folks, and there's roughly 10,000 individuals on that program today. We're trying to communicate that with them a couple of times in the near future, probably next week, to say, here's what's going on with you, and offer them a chance to raise their hand and be considered for full Medicaid coverage. Not everyone that makes it to that group has gone through that screening, so we want to make sure we give everyone an opportunity to move to Medicaid. And we'll do that yet again when that program does terminate. The month immediately following the PHE end date, so again, in this hypothetical scenario I'm giving, this would be the July 31st date. We would actually start to see our first Medicaid closures, and in this hypothetical situation, we'd see the COVID-19 group ending July 31st. We'd really see our first Medicaid closures closing around August 31st, again, if those are the real dates. And for those that are tracking the dollars, the enhanced funding ends the month following that, which would be September 30th in the example I'm using. So that's kind of a fun chart. As these things occur, we will be updating this chart with the actual dates that those things occur. And our intention is to actually create a website, which we'll talk about in a moment, that will house this information that people can go to very easily. And sorry, not website, I've been told that's incorrect. It's a web page. It's a web page on our existing website. So there will be a place you can go to see this information. Are there any questions about the timeline?
Jeff, I had one in the chat just around, I might have missed this. How many people are in the COVID-19 coverage group?
The estimates are as high as 11,000. I believe it's around 10,000 people. There's some reasons that number was off, but it's 10 to 11,000 people. Thank you. All right. Next slide. Here's where it gets fun. We're going to talk about who gets looked at first. This is the case priority and review timeline. And again, it had that fun name for the CMS report as we do. And this has some new updated figures. In the past, we've been talking about how many people are being held open. And the numbers we were using were incomplete information. It was from incomplete information in the eligibility system. In February this year, we were able to make a very critical change that actually indicates on the case to show us if it's being held open in some way or not. That incredibly increased our numbers. We're now at 106,000 cases, which is roughly 194,000 members. That is a lot of folks that we just don't know if they're in the right place or if they're not. It is entirely possible these are eligible people on the program that they're on, or that they need to move to a different Medicaid program, or over to CHIP, or over to the exchange. We just don't know what's happening with those cases, which is why we need to look at those cases in addition to everybody else on the Medicaid program. CMS gives us 12 months to start that renewal and 14 months to finish those renewals of every case that the state has. Utah's been fortunate that we've actually been doing renewals as we've been going along. And what that means in our state is that we can tell you how many people we don't know the answer for. Other states have not looked at anybody at all, and all of their cases up in the air, and they don't know what's going to happen with them. So this, again, I'm using that same hypothetical example here of a July 15th end date for the PHE, and that first closures, in this case being the COVID-19 group, would be that blue line on the graph you're seeing. Let me illustrate that with got the wonderful laser pointer right in here. That's where you'll see the first closures or indicator coming out of us if we're indeed able to start sooner. And there's a reason we may not be able to start soon as well. But let me talk about the order of who we'll look at first and see what questions that might bring. We have done some analysis on the folks that we are, and I'll try to use these terms interchangeably because I know we've talked about this in many ways. We talk about them as forced eligible. We talk about them as backlog cases. We talk about them as flagged cases, and we use that kind of interspersed throughout here. But the term I'll try to use the most is the backlog of cases. These are people we just haven't looked at, and it's the 106,000 cases we refer to. We need to put them in some kind of priority order, and we have to be able to tell CMS what that order is. So the way we've chosen to do so is that some cases are held open for reasons that make sense to us. About 10% of those cases we can tell you are over income, over assets. They're not a citizen. Something's changed in their household. And there's a reason that they don't belong where they are right now. For those 10%, we thought to put those in bucket number one. Bucket number one, simply, there'll be 12 buckets. And bucket number one will be then associated to whatever month this public health emergency ends. So in this example, we're using July as that bucket number one. So they'll be looked at first is what that really means. The light blue here is indicating the 90% of cases which simply haven't done their renewal. We don't know what's happening with those cases. And for that reason, we had to do a little bit more logic and a little deeper dive, which I'll talk about next. We actually did a scoring methodology, and I'll thank Brian Roach right now on this call for he's done some incredible activity to pull this data together. He incorporated a score for both the length of time that someone is held open. So if someone's been held open for 26 months, it makes sense that we look at that case before someone that's been held open for 3 months. There's likely more change that has occurred. He also did a really unique thing to look at the utilization of services. And that was actually interesting to CMS as we met with them this last week as well. We were able to pull people that are not using the benefits versus those that are using them more frequently. So those that are not using their benefits may be those that are actually not in our state and we just don't know it. So that gave them a little bit higher score and then again, pushed them more towards the front of the line. So if you're looking at the month of, in this example, August, you would expect to see more people there that have been held open longer and or that have a high score on not using their services very often. Another factor we tried to incorporate but happened naturally was we wanted to have a good program mix of cases. What that means is we didn't want to focus just on pregnant women or just on those that are on the adult expansion, for example. The reason for that is that Workforce Services, who's going to be doing this work, needs to have all the cases come in a good mix so that they can engage all of their workers at once and not overwhelm any given team. That happened naturally. It wasn't hard with those first two criteria. It just naturally happened. We didn't have to do any special mixing from there. And I will add that this is a little bit oversimplified in that there are some special groups we looked at uniquely. An example of that is folks who are duly eligible for Medicaid and Medicare. They have a natural time for them, which happens to be in March, when they can enroll for Medicare. Some people miss that window. It made sense that we put those cases into a later time. So in this group, it would be roughly in bucket 6, 7, or 8, where we can make sure we are talking to them at a time when, if they're no longer eligible for Medicaid, they can at least get onto the Medicare program. So there are some little nuances inside of that. And I will also add that the base caseload reviews that DWS is doing each and every month probably vary. So we have the ability to place more of these backlog cases or less backlog cases, depending on what the need is for any given month, so we can equalize that work for DWS. That is a mouthful, a lot of stuff to say. So this is the order and the priority for how we're intending to look at cases. I think I should pause. Let me quickly hit that note at the bottom. If for any reason the state of Utah or any other state looks at more than 1/9 of their caseload at any given month, we're quote unquote going to receive enhanced scrutiny. We're not sure what that means. From the eligibility perspective, it's a bad thing to do. You don't want to move too fast here. The reason that it's a bad move is that if you looked at let's say, one half of your cases and did that in September, next September, you have to look at one half of your cases and the next one after that, and it's going to continue on and on. It causes an eligibility bump that's uncomfortable for us. So for us, it makes the most sense to treat everybody fairly and equitably across the 12-month period. However, if you hit that 1/9 mark, CMS has been clear that the state would have to produce more information and criteria. I believe that's mostly in play for some other states. I think Wisconsin was one of those that was proposing to do this activity in 3 months, which I'm not quite sure how that's done. It's a lot of work that needs to occur, at least in our state. Let me pause and see if there's other questions here. Russ.
Hey, Jeff, thanks for the update. Hey, I was trying to follow your comments on duels. And so duels, Medicare has open enrollment. You were talking about individuals who you're going to try to look at them January, February, March. I guess I didn't anticipate actual duels losing coverage because they often qualify as disabled.
Correct. I think you're correct. Now, what I was trying to point out more than anything else is that there are some eligibility groups that make sense to be in certain months. That's one of them, that if for some reason, let's say that the person is over assets, might be an issue there. If they're over assets, they no longer qualify for Medicaid. We didn't want to leave them high and dry. We wanted to make sure that they at least had the ability to get into Medicare. What we have seen, and it's a small number, we're talking about 120 people, I believe, so it's a very small group. But in this case, we do have some that have not actually enrolled for their Medicare. They're eligible, they just haven't done it. And if they don't do that, or if we let them go at the wrong time, they're not able to get to the Medicare. So we want to make sure that we just, again, don't leave people high and dry where we can avoid that. So it made sense in that, again, in the comparison here, it's a very, very small group of people. But we tried that. If there was any other group that makes sense to do that, we tried that as well. And as I'm saying that, let me point out what that little purple group is as well. I should have done that, I'm sorry. We do have some cases we thought should be last in line. Those cases are those that are non-citizens. They are only eligible for emergency services. They too have been held open during all of this time. So for an example, someone could have had a baby back in 2020 and was on emergency Medicaid. Medicaid only pays for emergency services like the birth of a baby or a broken arm, that kind of thing. But that person has remained eligible all this time. It made sense to us to push those cases to the end, because if there is a new emergency that occurs over the course of these next 12 months, they're going to be coming in and applying for services, and it's one case we have to divert from looking at reviews and go back to that case. There are so many other protections in our natural system that only allow emergencies to be covered that it made sense to kind of push those to the end. But it's a good example of, I'll give a simple example. It's possible that there is a mother that has a single child. She is from Canada, of course, and not a citizen of the United States of America, but her child is. Her child has been held open for 26 months. The child's review will come up in July. The mother's review will come up at the end of the process. So there are some uniqueness to how the cases get looked at. Unfortunately, we would love to give someone one review date, but there are other pieces in play that don't allow us to do so. So it's possible that some families will experience a couple of reviews for some folks during the course of time that they're open here. In the case where we have forced eligibility, we did bundle all those review dates together with the exception I just gave. We did, so if there were 3 kids that were all held open, we tried to put that family together so that they do one renewal where possible. Great question. Thanks, Russ. Leah. And hello, Leah.
Hi, Jeff. So when you're working that child's review, if the mother is eligible, couldn't you go ahead and process her so that they don't have to?
Well, the case I was giving was that she was open for emergency services. She likely, assuming she had an emergency need, sure you could. My guess is that most don't. So again, we thought we just would leave that case open till the end. It will naturally close on its own after the process is over if there is no emergency need after 2 months, as you may recall.
Yeah. If it's a different scenario, though, where you were going to hold someone else towards the end, would that not apply? Or are you only saying that doing both reviews at once would only not happen in that scenario?
It would only not happen in that scenario, or if someone, so not everybody is, and Leah, unfortunately, she knows a lot about this, so she's gonna ask some hard questions here, but that's okay. It's possible that you have a case member who is not being forced, and they were looked at recently. Let's say we did a review and they're just perfectly eligible, and are good for another 12 months. We're not allowed to look at that. It's called a MAGI renewal. We're not allowed to look at that more than once every 12 months. So we couldn't bundle the sibling who, for whatever reason, needs to be looked at, let's say, and is getting pushed up in line. So we'll have to look at the siblings separate from the other in that case. So there are some technicalities that doesn't allow us to line up everybody perfectly. I can't take everyone in the household and say, okay, your review is in December, and then the next household, yours is in January. We're not allowed to do that. But where we can and where we were able to do so, we did try to align those. So specifically, if they were forced and had if that indicator is showing that they're flagged in the system, we tried to put anyone on the family that was flagged in that way together so that they'll be in the same month. Does that answer your question?
Yes, thank you.
Okay, good questions. Let's move ahead a little bit and we'll come back to anything you want at the end. We did get some legislative intent language this year, which was right in line with our thinking. So we appreciated that seemed to fit naturally for what Workforce Services ourselves and Human Services were thinking. But this is the intent language. It was given to us 3 times in the exact same way, so it must have been important. It's also how they give us intent language. And I'll let you read that at your leisure, but essentially it's saying that we need to make sure that we're communicating what's happening. And I have good news to report that we will be doing exactly that. Here is a snapshot of what you're going to see in just a minute, but and I know it's hard to read. We'll give you just a second to adjust your eyes to that. It is blurry. I apologize, but we'll show you that in more detail in just a moment. On this new webpage we've been talking about, we're going to be able to show you, for the first time, really show you some month-to-month data of what's occurring in the Medicaid program. It will be more than just talking about those cases that are held open. That backlog of cases for sure is some of the content. We'll also be looking at things like call volume at Workforce Services. What's happening with fair hearings? What about other cases that are being reviewed, which are some of the graphs you're seeing off to the side here? And certainly what's happening with applications. Are those moving up or down? And don't worry your eyesight on this one too much. You're going to see a better review of this in just a few moments. But what you'll really be seeing, we hope, is what is happening as we look at a case, make the renewal, and that family moves on to CHIP, for example, or they move on to the exchange. We're going to be able to show you that in more real time of what's happening, and certainly in more detail than what we normally present in this meeting. So that's very exciting for us to show. And there'll be a little demo of that in just a moment, so I won't spend too much more time on this slide. There are some other changes occurring. It's not just looking at cases. We've been doing some other emergency type items, and we just talked about the CHIP premiums in the last meeting for those that were there for the CHIP PAC meeting today. But we will be resuming CHIP premiums at the member's next renewal that occurs after the PHE ends. So again, using that same example I've been using of a July 31st date, which again, may or may not be right. Someone asked me in the last meeting, do you know that's the date? The answer is we do not know. It could be any time. We really don't know. Our crystal ball is as murky as yours, other than we have been getting some pressure from CMS to ask us more questions about what we're doing. So anyways, we will start CHIP premiums back up. Medicaid spend-downs, those people that pay each month to have Medicaid, will now be required for most folks. But again, those are people that are not being held in the backlog. For people that are held in the backlog, we're going to keep them in that status until such time that we pull them out and take a look at that case, which means they can behave exactly as they are today. And for some of those folks, up to 12 months, they'll behave just like they do today. We talked a little bit earlier about the COVID-19 group and what might happen with them, which is that they would end at the end of the public health emergency. One sec we'll get to you. The other eligibility components will also be returning to normal. So all the things that you may love or hate from before will be returning, like overpayments, sanctions if you're not participating in the employer-sponsored insurance, if you have medical support enforcement, meaning that an absent parent needs to be providing coverage, those kind of things will still continue. And then other flexibilities that were granted during the public health emergency might also end. For example, non-emergency medical transportation for non-traditional, et cetera, and the list goes on. Stacy, I think you had a question.
Yeah, just to clarify, with the optional COVID-19 group, this is just the people that remained eligible for like testing and treatment only, right? This isn't folks that rolled into expansion or other programs when they were found eligible?
Correct. Happily, okay. I can say this now. At the time, long ago, we didn't know if this would be a good move or a bad one. There were 2 ways to pay for testing in the early days. One was through a HRSA grant, which most people use. It's a little bit easier than Medicaid is, right? That money dried up just about a month ago. Utah was one of a few states, a handful of states, that chose to do this optional group, which allows someone who doesn't qualify for Medicaid in another area to get at least coverage for testing and testing-related services. And as I mentioned, under recent legislation, we're able to now add the ability to pay for vaccinations, which we are doing as well. So this group is a unique group. They're not treated like a normal Medicaid program in some respect, but it's a group, again, that's of around 10,000 folks that just have that unique, small, niche benefit for COVID-19. Good question. Thank you.
Right. Jeff, can I ask, well,
Yes.
also just kudos to you all for doing that. I know that was a lot of work to open up that optional group. So it's great. It's great to see that paying off. On the additional flexibilities, is that something that I know we brought up at last meeting too? Jen, are you going to be talking about in the director's report too? Okay, then I'll hold off till then. Thanks.
Okay. Let's jump to some, this is the fun part for me and what keeps me both worried and excited about the work that we do. And just to prove to you that even though this was updated just today, there are ongoing changes being made as we speak. And one of those I did mention in the last meeting as well, I'll do here too. So these are 5 specific notices that we intend to send out of the Department of Health and Human Services. So we will be sending these particular notices. They trigger at different times. One, I've already mentioned, we want to make sure that COVID-19 group is understanding that they have a limited benefit, but if they want to raise their hand and be looked at right now, that they can do so. So that notice will go out probably in the next week or two. The first there, number 1 is the general notice. Once we get a 60-day go-ahead, we actually know what the real date is, and this is how government works. We will take that date, we will put it into our already prepared notice, and then we will go to print around 270,000 pieces of paper, stuff them in envelopes, and get them out to people. That's going to take us a couple of weeks. It looks like it will take 2 to 3 weeks before that actually can happen. We'll do it as fast as we can, though, to simply let people know, look, you're hearing the news stories that the public health emergency has ended. That probably impacts you in many ways. Here are some of them that will have some impact to you over the next 12 months. We do not want to create hysteria. We do not want people to worry. And we really, truly do not want people coming. We only want them coming in line. We don't want them all coming at once. If all those folks we just talked about were to rush DWS, it's going to be a long several days as we try to figure out what to do next. We really need, there are so many cases to look at. We need to make sure that we're managing that workload across the 12 months. Other notices we intend to send are one specifically to CHIP to let them know about those CHIP premiums. One to the spend down population to let them know that, before if you didn't pay your spend down, there was no harm, no foul, but now it matters. And again, to those folks that are on that emergency Medicaid type of program to let them know that we're going to keep them open, of course, but also maybe they've had a change that we need to take a look at. Please let us know as soon as you can, that terminology of raising their hand. Here's the new thing that we're going to do that we're stealing, and we're going to borrow all the good ideas we can from you and from any other state that comes up with them. From New Hampshire, we learned that they're going to send some notices out in color. They found in their state that they've been sending some notices out, and to get more attention to those notices, they wanted to do something different. So we're doing the same thing. We got approval just yesterday to put some notices in color, so they'll come on a colored piece of paper that will still be readable, legible, that kind of thing, but able to be noticed maybe in a little bit different light. We talked to Workforce Services just yesterday about the same thing. There are some notices that we could do in color that maybe for that first CHIP premium, for example, can we put that, in the old days we used to use a blue envelope or something like that to trigger something for that person to say, oh, this is different, let me take a look. We're hopeful that that type of format might help. We also tried to write these notices in a very, soothing isn't the right word, but in a very soft way to say, here's what's happening. We're trying to talk to the person, less governmenty, if you will, and a little bit more friendly on the notice language. And we're using folks from this very meeting that have joined us to help us with that language, and we appreciate that. So these are 5 that we'll be sending uniquely from us that we've identified so far. We may add to that list if there's other groups that we think that we should see. I'm going to skip ahead a little bit. This is the part we should talk about for just a moment, and this is, I think, our last slide, which is that there are some problems that could occur, and there's certainly some risks, and we're aware of those, and we're trying to do everything we can to ensure that that smooth transition we've been talking about can occur. So certainly there's some questions about eligibility staff. We know that. I'm worried about them doing this for 12 months. That's a long time. I'm worried about overtime. I'm worried about will they be trained in time, et cetera. We're worried about that increase to fair hearings. We haven't had a lot of fair hearings because those usually only come when you deny benefits or close benefits. That might increase. Are we ready for that? We know that we've had outdated contact information. We've talked to you guys about that for months. One of the things that this whole thing has done, it's solved eligibility churn for us, right? Once you got on Medicaid, you stayed on Medicaid. But we're going to bring eligibility churn back. It's possible that a case closes, but they weren't aware that their review came up, their case closed, it's been 3 months, they go to the doctor, hey, my card doesn't work. It worked for 26 months, what happened? So we know that that's going to happen. So we're going to be watching for that. And then of course, and I alluded to this earlier, we want to make sure our eligibility system's ready to go. Due to no fault of our own, we are moving the data warehouse that holds all of our machines, all of the actual eligibility system is moving. We're actually moving it to the cloud in this case. It's to get rid of the building behind the Capitol. That's going to become a museum, I understand. And we were forced to get 70 servers picked up, ready to go, and we had a couple months to get it done. That activity will be hopefully done in June of this year. So you can see that if the timeline I've been using is true, we're really in a pinch to be able to start doing any processing early. And I meant to say this before too, if you do start looking at cases early, it means you start your buckets early as well. So you get 12 months. We had hoped to get, hey, can you let us start early on this and give us 12 months? And the answer was, no, you can start early, but it counts. It counts as those 12 months. Other items that we should just be aware of. Certainly we have a merger happening with 2 agencies. Hopefully no impact here that we can see, but you never know. Legislative session that will happen within that time frame, of course, and we're launching our new MMIS system in the background that will happen in January this year. So, January 1st of next year. So that's a lot of activity on its own, and this activity of this unwind is going to be happening in the background. So I'm going to leave with the final quote here of, this is meant to be a marathon. It is not a sprint. So, and back to that same idea of we need to move through this as methodically as we can so that we don't have a rush. We're not getting people out of turn, that we can actually see the folks at the right time. And to that, our message is slightly changing. Before I've said, hey, make sure people do the renewals, and that is still true. If we are asking them to do the renewal, please ensure that they do so. If it's not their time, we'd ask that you actually have them wait until the renewals due and have them do it at that point in time. And that was a message from DWS I heard very clearly yesterday. So with that, I know there's probably some questions, but let's quickly show you the dashboard if that's okay. And we'll just show you a quick demo, which will be kind of cool here. So I'm gonna let Michael take over the screen if you would.
All right, I can share my screen.
We're going to walk you through the first ever eligibility dashboard for the state of Utah, and you're going to see it as we all see it together. This is going to be kind of fun. And kudos to Michael for putting this together for us and being able to pull the data together. So thank you. This will be added to our infamous webpage I keep referring to that we don't have the actual website for yet. We'll give that address as soon as we have it to this group. And some of this is using real data, which is kind of exciting. So this first graph here on the top is actually using the data. We were talking earlier about 80,000 cases, now 106,000 cases. I'm not sure it's got the last data point added, and that's okay. The purpose of this is you'll see on the top there, across the top, we have 4 or 5 different tabs. The thought is we wanted you to be able to play with the data. So you'll be able to log, obviously go to the website, it'll be open to everybody. You'll be able to see this data, and just simply selecting the tabs at the top, you'll get different pieces of information. Thanks for showing that, that's neat. So there's different graphs on different pages. With each of these, we'll try to put a definition out to the side so you know what we're talking about. And we've tried to title them in a way that makes sense to us. We need your help to make sure they make sense to you. For example, this one is trying to show the backlog cases and individuals that are pending renewal. And this is going to be a mountain of work that over the 12 months should be decreasing slowly back down to 0. Hopefully 1/12 at a time. And then you'll see the cases completed. So we wanted to show that both the work that's happening and that mountain of work that's decreasing over time. We're hopeful that that's going to be helpful. Can we show the review outcomes? As soon as you do that work, we wanted to be able to show you where did people go. These graphs, and this will be, you can hover over that and get some information as you're seeing as he hovers the cursor over, which is really pretty cool. We're trying to show you in a stacked bar graph here, the 3 different breakouts of the people. So as we complete a review, either they're going to stay with us, meaning with Medicaid or CHIP in some capacity, or they're going to move to the health exchange. We'll be sending them that direction, or they are falling off the system altogether. We don't know what's happened to that case, typically because the renewal wasn't completed on time. So if that occurs, you'll see that 3 breakout for any given month. And that graph is meant to grow over time. So you'll see the history as it occurs. The bottom graph is going to show the aggregate of that detail. So you'll see overall what's happening with the backlog cases on your left. On the right-hand side, we're comparing that same type of statistic to what's happening with those regular routine cases that are renewing, and normal things happen there too. It's quite possible we looked at a case that's perfectly eligible and mom gets pregnant next month. It might mean a change in the program, et cetera. So as those cases and those renewals occur on both sides of that fence, you'll see what's happening with the backlog cases, which we think may look a little different than what's happening with other cases. And you'll be able to do a comparison. So that's kind of a fun one, we thought.
So Jeff, I'd also want to add that with these graphs here at the top, right now there's only 2 months displayed, and this is all fake data. Once there's more of a trend going out, these graphs are going to show that trend, and so they're going to look a lot better. I just wanted to add that.
And I think it was Michael Hales, I think he asked us to include some color, and I think Michael Keith has done a great job of adding color, so just wanted to point that out too. The next chart was asked for by the CHIP director and some other people that wanted to see what was happening with Medicaid to CHIP. Is that going to grow or not grow? Again, this is fake data here, but we wanted to see what was happening. Are we going to see that shift to CHIP that we thought would occur, and what does that look like over the period? So this will be over that whole 12-month period. The next one shows a lot of activity. This is the one I showed a picture of earlier. This will show the application. Again, most of this data is faked up for this purpose today to show you what was happening. DWS, I know Maurice, you're on the call. If you want to chime in, you're welcome to as well. We anticipate seeing applications may tick up as cases are closed for whatever reason. We think that we might see some of that activity. This would be your churn. We also are looking at how fast DWS is both approving or denying cases and how many cases are left pending. We're looking at the average day to decision, how fast DWS is able to move. You'll be able to see some baseline data of what was happening right now versus what happens once all those reviews are on their plate to do. You'll see the same type of thing with fair hearing requests. Right now, they're probably pretty low. As a matter of fact, I don't know if we ever hit 60 in a busy month. So it'll be interesting to see what happens there. And then we thought it'd be interesting to show some of the other work that DWS is doing with food stamps and financial aid, et cetera, some other programs that in the yellow there. And then finally, the call volume, what's happening with the phones. We anticipate more calls will be coming in, of course, and it made sense that we had some metric there to show what the call volume at DWS might be. And then the final page, I believe, this is an interesting one that might be a canary in the mine for you as we specific to churn. This is the presumptive eligibility or the temporary Medicaid eligibility, and this is real data. This one will show that the hospital, that light blue color, those applications have been declining over the past, and these, I believe, are quarters. It's hard for me to see those data, but I believe those are quarter points.
They're months.
Oh, thank you. Yep. Thanks. So if you look at it over even a longer period of time, this has been declining for the past 26 months. This is something that it should be going down. We don't need to do temporary Medicaid for folks because they're already on Medicaid and they've stayed and remained there. I do believe that this will tick back up once cases start to close and someone shows up at the hospital or a clinic setting and needs to get access to coverage. You'll see some of the presumptive eligibility numbers jump up. And you may see those jump up before we start to see the applications going back towards DWS. That is a lot of data. So first of all, thank you so much, Michael, for putting that together and for your ability to show that today. Let's just open up to the questions you guys have on anything you've seen.
I have a question. I'll just kick it off. One just point of clarification is not closed. Sorry, in the slide around not closed. Is that that just means going to another program within Medicaid? So is that correct?
Correct. So this is on the first chunk, I believe, Michael. Review outcomes, the second tab. We're trying to show, we're splitting into, it's very high level. We're trying to split people into 3 groups. After their review is completed, did they go to the exchange? Did they stay with us? Or did they fall off altogether? So that's your breakout. And we're doing that across both the cases that were backlogged, the 106,000 cases that were backlogged, and then the other cases that exist in Medicaid. So you can see a comparison.
Yeah. Okay, great. That's helpful. And then actually, I see Stacey with the same question. My other question is just around call volume and whether or not, yeah, I mean, this is really terrific. So I just want to say, first of all, this dashboard is amazing. I think I've already been, you've seen my enthusiasm, and but I'm really excited about this information. So thank you all for the work you've done on it. For call volume, is it possible to see things like, wait time, or call abandonment rates, I guess, too? Because I feel like that will give us a better sense of what the where consumers are. And, I think it can also, that's just another piece of the puzzle that's really helpful to see.
Jeff, if you want me to answer that, I will.
Sure.
So the hesitation here is to share the data that's really meaningful and give you information that we can kind of reliably react to. Some of these metrics that you talk about, the call abandonment rate and call wait times, are metrics that we capture, but are also metrics that we feel that we should sometimes restrain from overreacting to, because they include some of the elements as well that, like, for example, we offer callbacks and we offer options to where we actually staff our queues based upon staffing and resources. Call volume will probably tell you the best story in terms of how are our phones doing compared to abandonment rates versus call wait times. It is data we capture. We can certainly at times provide what is needed, but we really wanted to focus on providing you with the data that we can reliably kind of do something about or use to make some assessments or draw some conclusions.
That makes sense. I appreciate that. I'm wondering if we could start off by including that information, and if it feels like it's not telling, I think, at this point, it's so hard. The more information I think that we have, the better. And I appreciate what you're saying, but if it's an existing metric, then I'd advocate to include that now. And if it feels really off, then let's have that discussion and dig into that, and you can provide that context versus not seeing it at all. So I think that would be my just a one, for that area, that would be my request, to include that information if we can, if it's already available to you.
Yeah. Well, thank you. I think we should take that under consideration.
And I'd like to add that the CMS is also asking us to provide, all states need to provide a lot of information to them. Those are some of the metrics we're sharing with CMS. So there's a whole slew of activity that they would like to see from us. Everything you're seeing here is also being shared with CMS. And so that information will be going to them on a I believe it's a monthly basis by the 8th of the month. There's some question of whether we're going to show the data at the same point in time so it's consistent, because I'm not sure how CMS is going to use that data. If they're going to publish it in some way as well, I don't know. But we'll try to do what we can to make sure that's consistent with what they're seeing as well. I see a couple hands. Todd, I think you're up first.
Yeah, thanks, Jeff. So just I have a question going back to the work that you were talking about with Equifax to do address matching. Will you then be updating addresses in the system, and will those addresses be transmitted to the ACOs?
The answer is yes. If we update the address, you'll get it. We're going to send those to the health plans, of course. It's a tricky thing to do. And one of the things that's really neat about the Equifax experience, from what we're learning, is, again, it was fascinating for me to learn that they update the Postal Service. I thought that they were the gold standard, right? And to hear that these guys make them the gold standard is helpful to us. The other part is that we asked specifically that they give us the most recent 2 addresses, and if they can, when did they get it? Because it's entirely possible that DWS has the most recent address, and we don't want to overwrite that address. So as you can imagine, this is a list of now 106,000 cases. We're even talking about doing it in 2 batches to see if we can look at that data, have someone actually scrub it a bit to see. We're not going to simply just take it. We have to look at it and make sure that their date or their address is better than our address, or ours is better than theirs. Make that call and then update it. As soon as that address is updated, it does transmit to you. And I don't know that I can tell you exactly how that occurs, but I'm sure there's someone on the call that can. But it does update to the health plans, I believe, after the batch runs that night.
Yeah, absolutely. And that would be my understanding on that. I guess wondering how, and you answered the question. I mean, in the work you'll do to validate what address you would use. I guess that what I was really wondering was when you were saying they might give you a couple addresses, it's like, okay, are you going to maybe give us those 2 addresses and we can try out which ones are right? But I think we're fine with you guys doing work on that end.
Yeah, the purpose of the 2 addresses really specifically was to say, if I know the address is, I don't know, Smith Avenue, and they give me Smith Avenue and Jones Avenue, then that gives me a really quick indicator. Oh, then the Jones is probably new, and that's probably the right one. But if I see in a different order, or it's possible they're seeing the last address we had and then the current address that we also have. That just validates what we have is right. So you have to, it takes a human being looking at it. It's going to be an interesting experience to get through a lot of information very quickly. The good news is that we can do that activity before we start to look at the reviews. And that was the critical piece here. And the cost seems like it's fairly reasonable to do overall. Maurice is paying out of his wallet, so he's got this fully covered.
Appreciate it. Thank you.
And then I think Stephanie?
Thank you. Yeah, I just wanted to say thank you for all of the work that y'all have done, and I appreciate the dashboard, and I'm excited about all of that. And I just wanted to, yeah, I echo Jesse's request. If we can get some of that data about like call wait times and things like that, I do think that really impacts the the applicants and the members, and so that would be helpful. But I really appreciate all this. And then my other question was just about to Todd's point, I'm wondering like if the plans and the hospitals have figured out like if they're going to also do some work on the data to I think we've talked about this before, but in my experience, the hospital often is like who has my most updated address, because my providers are who I have the most interaction with. And so I'm just curious if there's plans to get like the health systems and hospitals and provider groups and the plans to also get that information like bi-directionally. Like I get that y'all might want it from Equifax, but in my experience, like I see my providers so often, they really do have my most updated everything. So I'm just curious if that is also a part of this plan. And sorry if I missed that, if you already said that.
I don't think I did say that, and so thank you for that. So that actually naturally occurs. We built that in long ago, that health plans can give us the updated information that they get, because you're right. It's possible the doctor's office has a better address than the last time I saw this person was 8 months ago. So if they can give us that address, we at the time passed it to the health program representatives, and then they sent an email to DWS and eventually got updated. Now we actually directly update it. So we actually are faster at that process than we were in the past, which is really pretty neat, I thought. And they don't come in huge reports. They tend to trickle in, like kind of onesie twosies, but there are several. We can actually tell you how many we update on a monthly basis if that's helpful. We've been doing that for some time, and we'll continue that forward, because we agree. We want to make sure we have the best up-to-date information. Another piece we could talk about is we also enhance the information we share with the exchange. We learned not too long ago that we weren't giving them email addresses. We had the email address, but we weren't sharing it with the exchange. So we're trying to work with our partners as well to make sure that they get the updated contact information. We tend to hold EREP as the source of truth, and we hope that's the case. But you're absolutely right. If there's a better address coming from either Equifax or the health plans or anywhere else, we want to make sure that we take that into consideration and update it where we can.
Thank you. A follow-up to that is just, so I get that the health plans update y'all, but so I don't talk to my health plan, right? I talk to my providers. So like, even though they're kind of owned by the same, but anyway, so how often does the providers and the hospitals and health systems interact with the plans to get those like, is that also like just a very regular constant thing, or is it like a monthly sweep of address? Like how does, I guess that's what I'm curious about. And if there's efforts to like make that, like do that more often around the time of the unwinding, or I guess that's what I'm just curious about, is how often that's happening on the hospital to plan side.
That's something that I can't speak to. Some health plans that are here are.
You want me to talk to that? This is Brian. Yeah.
Great.
I mean, I think maybe there are different health plans that do interact more with their providers, because they're like you were saying, they're owned by the same company. But we rarely have conversations with hospitals or providers where we're asking for information about addresses and phone numbers. The only way that really comes across is if either the member calls in, and every time a member calls in to the health plan, they always ask for that qualifying information right up front. Every time, doesn't matter if you call 3 times a week, we're still going to ask you. But the other way is through our case management. When case managers are helping individuals with special needs. We're always asking for that updated information, address, phone number, all of those things. And as we get that information, we can send that to the Department of Health, and they will get it to DWS and make those changes.
Thanks, Brian. That's, yeah, thank you. So there kind of is, it's kind of random then, is that?
Yeah, I mean, in terms of like, I know you were talking about, health plan to hospital, health plan to provider. On a rare occasion, we do speak with them when we're doing case management. But other than that, it's really when the member calls in or when we call the member for whatever reason, we always get that information from them.
Okay, thank you for the information. I appreciate it.
Yeah, yeah.
I think we have Maurice, and then Russ, if you still want to talk to.
Jeff, thank you. I just wanted to kind of address the group and with a small request. Just an explanation. We've done our best to prepare for what's coming our way, but make no mistake, what is coming for the eligibility worker in the future is a very tall ask. Jeff, at the end of his presentation, said this is a marathon, not a sprint. For those of you that know some eligibility workers or know any of us here, we don't have the physique for marathons, maybe not even for sprints. So I'm just asking for your guys' support in knowing that this is a tall ask for our eligibility staff. We currently do roughly about 14 to 15,000 review in a month. We're going up to 23. We're asking our staff, without giving them additional resources, to really do quite a bit more work than they are used to doing. And even today, they are stretched between applications, change reports, phone calls. I mean, we currently have folks who have been kind of stretched thin when their caseloads have grown during the course of the year, with our staffing numbers stay the same. So what I wanted to just kind of reach out and ask for your guys' support as we go through this process. Our application numbers are going to go up. Our application average days to decision is going to most likely increase. Our call volume is going to increase as well, as will our call wait times. But we need your guys' support to do what we need to actually be doing. One thing that we don't want to do is we don't want to overreact to some of these things that we can measure, but also focus on getting to the root cause of the issue, or the phone call being created, which is get that review done, make a decision for the customer so they can either smoothly transition or remain on Medicaid. For that, we will need your guys' support, and I'm just asking for some understanding and support as we kind of embark on this.
I saw a few hands come up, and some of them got down, so I'm sorry about that. Let me see if I can get the queue. Stacy, I think you're next.
Yeah, I thank you so much, Maurice. I know that this is going to be a lot for your team. Just wondering, this might be fantasy thinking, but is there going to be any support on this from DHHS staff? Is there any bandwidth at all in that department to help take on some of this workload or help ease those burdens?
Oh, we would love to help out in what ways we can. So our staff is fairly small. Since you don't know, Stacey, we have about 8 to 10 people that formerly were eligibility workers. I'm one of those. I'm the least likely guy you want to have messing with anyone's case. As a matter of fact, I think MERS took EREP away from me. I can't get in there, and that's probably good. We're a little bit out of touch, I think, with some of the current things. That's not the case for all of us, but we have some workers that could help a little bit. Our focus is really going to be making sure that the process is moving through. We have a lot of work on our side to report to CMS to make sure that the information is traveling back and forth as it should. So we have a lot on our plates as well. I wish we had the bandwidth to help out in a more meaningful way. I will say that over the past several months, and we've been working on this for months now, we are doing this hand in hand. Any way that the Health and Human Services can help, we will help. Again, we've talked about address updating. We've talked about pulling the information together, presenting the information. There's a lot of that we can help with, and we are where we can. I wish we had the bandwidth to do more.
Stacy, the other thing I'll comment on, I think the biggest help that we could have received in this process from Jeff and his staff as well as some others in DOH. And again, shout out to Brian Roach, who's really helped us kind of make this so it's a steady number of reviews that are coming each month, and using some really good logic to help us achieve that. The biggest help we needed was in the planning stages of this, and I think that has been provided without any any hesitation or reservation from DOH's side. So I think that the assistance we were hoping for, we certainly have received. Now it's getting some of the grant work done, and we have some experience in that. We'll do the best we absolutely can.
I'm not seeing other questions right now. Before I pass the time back, maybe I'll just let the group know that as we do our eligibility reports going forward in the MAC, as the unwinding occurs, whenever that is, we'll certainly talk about this data as well. It's going to be easily accessible to you, but we'll talk about what we're seeing and what's going on, any trends, anything that's happened of interest in that realm as well. Until that time, we'll be coming back with any updates. If another great idea falls out of New Hampshire or anywhere else, we'll take it and we'll tell you what we're doing with that as well. Or if there's enhancements to the metrics, that kind of thing. So we'll bring those things back to you as those changes occur. I think we hit our 30-minute mark at some point here. So I'll turn the time back over to Jesse. Thank you so much for letting us talk to you today.
Yeah, thank you, Jeff, and thank you, Morris, both. I know we're a little over time. I think we'll be able to make it, but I appreciate. I think this was a really important conversation, and I want to just say too. I think this is going to be a learning curve for all of us. Obviously, that's an understatement, but I think the more, I guess, I mentioned this earlier, but I think the more information, the better. If we will, I think also help us all kind of move forward with trust and transparency. I think that's. I just want to encourage that. I think the more. And this is what this dashboard is so great, and I think such a model for other states. This transparency, I think, is what will help us be able to respond and to help move. I think will make it a more effective. So, as much as possible, I think sharing this information and updating as regularly is just really fantastic. So, thanks all for your work, and look forward to moving forward in that spirit and recognizing how tough this is for everybody. So, thanks again. All right, let's see. Tanya, do you want to do the AR? I think we'll be okay because you've got a little extra time at the end there. So if it's feeling crunched, we can make a revision to the agenda. But Tanya, do you want to share about the ARPA funds?
Sure. Yeah. Thanks for just a couple of minutes. We touched on this briefly during the last MAC meeting, but just want to remind folks that based on the ARPA funding in March of last year, so March of 2021, there was a provision in the ARPA law that allowed for an enhanced federal match for home and community-based services that were provided. And with that match, some guidance about what states could use that funding for. So states had the opportunity to do things like raise provider rates, which we implemented actually pretty quickly after we received the ARPA funding. So just a reminder, for home and community-based service providers that include home and community-based waiver providers, home health and personal care providers, some behavioral health services, school-based services. All those providers received a temporary supplemental quarterly payments to help to address like direct care workforce issues and a variety of problems that providers are experiencing as a result of the public health emergency. So that was a project that we implemented right away based on the available funds for this home and community-based improvement. Along with that, the state had included in its spending plan a variety of other projects for which we sought CMS approval to use these enhanced funds. And so there's a variety of projects that the state is working toward implementing. One that I wanted to just touch on quickly. A program called Home and Community-Based Services Infrastructure Grants. And with this funding, will be putting out an RFP on May 2nd that will ask, and it doesn't just have to be enrolled Medicaid providers, but a variety of entities. So it could be a nonprofit organization or other entities who have ideas and projects that they think will help to improve, enhance, or expand home and community-based service infrastructure in Utah. And we have, in our spending plan, we've described it as about right around $5 million, and we're likely going to reserve a little bit of that money just to make sure that we have a sufficient budget to take us through the end of the program, which will be March of 2024. But with those available funds, we are inviting entities who may have ideas about how they can help with the HCBS infrastructure during the month of May to prepare their request for proposal and submit their applications to the state to be able to use this funding to support their whether they're a current provider or other entity to improve our system. It could be used for some things that are familiar for those who are familiar with home and community-based services. There are a couple significant federal changes over the last 5 years or so where providers are required to take on some additional responsibilities as it relates to home and community-based services. One of those is a federal regulation known as the Home and Community-Based Services Settings Rule, which requires states to make sure that home and community-based services are individualized. They're provided in settings that truly are home and community-based and not institutional in nature. So if providers have projects that can help to further their efforts there, we really encourage all providers to apply and use this money. It's a kind of a special opportunity to use these ARPA funds because we're able to go outside the bounds of what Medicaid typically pays for. So we're not receiving federal match for this project, but it does allow us, and CMS requires us to use the savings that came as a result of that 10% enhanced match to use it for projects that Medicaid typically wouldn't be able to fund. So it is a unique one-time opportunity for providers. And we put out some FAQs and some other information on this through our email, like listservs and other opportunities. DSPD posted it on their website as well. And I don't know, Sharon, if that was included in the information that we sent out today. We also plan to publish, likely publish an article in our Medicaid information bulletin. But we really want to get the word out. So any help that you all can provide with this too. And Sharon, if we haven't provided some of these documents, if we could do that to the MAC members, I think that would be great.
Yes, absolutely. I will send that out to them with that information.
Thank you. So probably, Jesse, that's the one that I would just touch on today, and maybe we can bring others back as they're getting closer to implementation. You know, this one, again, it's May 2nd. We really encourage providers and other entities to think about how they might use these funds and submit their applications. And then we'll bring back other projects as they're getting closer to implementation.
Thank you. And if there are questions, would reaching out to you be the best thing to do? Okay.
Yeah, people are more than welcome. Joseph is highly engaged in this this project as well. So, you know, any of us are happy to respond to questions on this.
Thanks so much, Tanya.
Yep.
Great. All right, Jen, over to you.
Thank you, Jesse. Looks like I'm scheduled to talk about UTA passes. So last month, I did introduce a change that's occurring through our UTA, Utah Transit Authority passes for Medicaid members. So this change specifically is moving from a paper punch card pass that Medicaid members receive on a monthly basis. It's a paper card. It's mailed from DWS, and it allows the member to have 12 rides per month. And the paper punch would be punched as the member were to ride on a UTA transit vehicle. And this process is, the paper pass is actually going to be ended on July 1st. And so we've been in the process of transitioning this program from this paper card that sent out monthly to a digital touch pass card. So this will be a plastic card that's has a chip embedded in it, and it will be sent out hopefully like once, and then the member will remember to hold on to it and then be able to use that continuously as they're enrolled for Medicaid services. So a few things I'd like to update you on this week or this month for the work we've been doing are around some of the transition planning we are doing for this. So the one piece is that this is definitely a change in the way things are done today to the way things will be done after July 1st. And the digital touch pass card actually will not be distributed by DWS. It will be distributed by Medicaid staff. And so there is a whole different pathway for requesting and then receiving a card now that we have a digital system rather than a paper system. So with this, what happens is really the central place where we will be gathering member eligibility information, and those that actually request or are eligible for a card will be in the My Benefits portal. And there's two ways that we can operationalize this. One is that the member can log into the My Benefits portal and actually request a card. So there's a series of questions that the member will be prompted to answer that ensures that the policy around using receiving a UTA card, that they meet these requirements. And then at that point, they can also ask for a card if they qualify, or a guardian. If it's a child, the guardian or parent can do that as well. Or if they have an attendant, that will also be done through that. The second option, if the member does not have access to the portal, is for the member to actually call a health program representative and request a card through them. So the HPR will actually log into the portal and go through that process with the member so that they can get a card. Now, early on, we realized there is a huge transition moving close to 16,000 members who are receiving paper punch cards monthly to a digital touch card process. And so we are going to be doing a mass mailing on the first time. And the way that this is going to happen is that when the member eligibility file is released at the end of May, that file is going to be sent to us to help us identify exactly who is eligible for a UTA pass. So Department of Health staff or Medicaid staff will take that list. We have a letter that we are drafting that describes the card and the benefits, sort of in an FAQ process, and will also contain the card in it. So we will auto send individuals who continue to be eligible and have been receiving the card, this card in the mail. And so this process at the end of May will occur, will be really truly stuffing multiple thousands of cards and these letters into envelopes. And the way this works on the back end is when the member has this card, the UTA chip inside will be assigned to the member within our system. So we know who's receiving which card. This file then gets sent to UTA to be activated for July 1st. So the mass mailing will take place somewhere around the first 2 weeks of June, so that the member has the card before July 1st. And we can continue to mail out extra cards, other cards if people become eligible and want a card before that time. But in the meantime, there is a stuffer that is going into some of the materials that are sent to members now, so that there is sort of an update and awareness of this change that will be sent to them. And then subsequently in May or early June, we will be sending out the card to the member and or the member's guardian or family. So we're working through all those processes now, and ultimately we will be able to gather much more discrete data around member use patterns of the UTA system to receive medical services and members' use and things like that. So we're able to track utilization patterns and things like that. So I think that's a large chunk of our update now. If you have any questions, I'm happy to take them. Sorry, Stephanie, go ahead.
Hi, thanks, Jennifer. I'm excited about this. I apologize if I missed this. Are the criteria, so right now, I think that you can't use these passes to get to like the pharmacy. Like there's like lots of restrictions. Are any of those restrictions changing? And I'm so sorry if I missed that.
Yeah, I didn't actually touch on that specifically, Stephanie. And the policy does state that the card, like we have the card that was designed and it says medical transport card. And our policy is for medically necessary appointments, right? Medical appointments. And of course, our policy is aligned with medical necessity, right? So physicians' appointments, things like that. Historically, this did not include a unique trip to the pharmacy. If the pharmacy was part of the journey, then that was okay. If the pharmacy, like you went to your provider's office and then stopped at the pharmacy as part of that journey, that was acceptable. But the policy today does state that a trip specifically to the pharmacy would not be considered, it would not fall in line with the policy. That is something we've taken back to evaluate as certainly a consideration and to determine, I don't know where that came from, to be honest, Stephanie, but we've taken that back for evaluation.
So that might be changing then. There might be.
Yeah, we're looking at that. Is it, looking at what makes sense to get continuous medical care, right? With regard to medical appointments, being able to pick up your prescriptions as part of that, or go to a laboratory and then pick up your medicine, something like that. And so it's definitely a piece we're looking at. Yes.
Awesome. Yeah, I think that is a reason some people end up in the ER. So I think it would be beneficial to make sure there's some more flexibility there, but excited about the progress here. So thank you for all of the work y'all have been doing.
Yeah, and I'm glad you brought that up, Stephanie, because that's an important change that we need to look at. So thank you. Are there any other questions about UTA? Okay, we'll bring you more next month as we get closer to a go live date with this. We'll bring you updates in May. Okay, go ahead, Jesse. Do you want me to just transition into the director's report for a few elements?
Yeah, that'd be great.
Great. Okay, so a few other highlights I'd like to cover as part of the director's report this month. And some of these are kind of a connection with things that Jeff has already spoken or talked to during his presentation. But the first piece I'd like to just touch on are our COVID uninsured population, to note that there has been submission to CMS for coverage. We have been covering testing for the uninsured population, but there has been also a submission to cover medications as well as vaccinations for this population as well. As Jeff noted, that coverage would retro back to March 1st and then continue through the very last day of the public health emergency. So these provisions have been submitted. Our systems are being programmed now to support this transaction, and that is moving forward with that. The other piece of that is there has been a question with us as we look. Jeff presented, lots of detail around the unwinding activities having to do with our eligibility and our membership. There's also extensive work being done to look at, evaluate our policies and the coverage changes that we put in place as a result of the PHE as well. And one important step that we've looked at is a lot of medicines as well as even tests for COVID have been approved under an emergency use authorization and haven't received full FDA approval. Typically under Medicaid coverage, we don't cover experimental procedures or experimental services. There has been an exception for COVID-related treatments as well as vaccines and tests through the duration. It will extend under the ARPA rules for an additional year following the end of the PHE. So there has been an additional submission for an ARPA SPA to be put into CMS to extend our coverage of both COVID-related treatments with regard to the oral and infused medicines, as well as the vaccines and any testing that may not be fully FDA approved, but may be authorized under an EUA as well. And it would incorporate those that are as well. So it would incorporate both approved and EUA approved services through at least the one year after the end of the PHE. So that work is, that has also been submitted to CMS. As we have other coverage policy changes or areas of interest, we will bring these up as part of our comprehensive unwinding activities as well. Another item I'd like to update you on is the consolidation efforts and some of the work we've been doing here. One change that we have, so just to back up, we know that the purpose of consolidating the Department of Health and the Department of Human Services is to improve the quality of and access to services for Medicaid members and others receiving services through these programs. We know that existing as two separate departments, we have created some artificial silos between the mental and physical health plans, as well as individual and community health, that really do interfere with our overall goals of whole patient care, as well as our objectives to improve efficiencies, as well as manage the costs of this population. So we are moving forward, and two important ways that I'd like to share with you now is first, that as we've mentioned earlier, Medicaid will exist within the Division of Integrated Healthcare. And as part of this change, substance use and mental health, as well as the state hospital, are working within our operational unit. So one of our new words we're using as far as naming our healthcare administration unit, and our operational unit is the Division of Integrated Healthcare, will encompass Medicaid, CHIP, substance use and mental health, as well as the state hospital. So with that, there are some important changes with regard to, first of all, substance use and mental health, and the state hospital are managed and overseen by Brent Kelsey. And I know I may have touched on this before, but officially that group has moved into the Cannon building. So physically we are in the same building on the third floor now, and this move took place last week. And so we're really excited. Brent is also an assistant division director as part of our director's office. So he will be part of the director's office with Eric Grant, Brian Roach, and myself. So we're also all working together to encompass this and operationalize this vision of integrated healthcare. And the important work we have to take place, we're already getting started on several different items where we're working collaboratively on them, and in the process of getting to know each other and begin open communication and dialogue. Tanya, is there anything you'd like to share in addition to that?
Yeah, thanks so much, Jen. Just a couple of quick items. In addition to the move that Jen just described with the Office of Substance Use and Mental Health, the Cannon Building has a couple of additional groups that are now part of the Healthcare Administration section as well. So the Division of Services for People with Disabilities has moved from the MASOB, the multi-agency state office building, and are now in the Cannon Building, as well as the Division of Aging and Adult Services, along with the Office of Public Guardian. And both of those divisions are located on the 4th floor of the Cannon Building now. So all of the healthcare administration section that Nate and I are working together to oversee are all located in the Cannon Building now. And we think that will be a nice opportunity for some synergy for us as we go about our work with the leadership and the teams overall. And then I just wanted to mention quickly that, and I haven't mentioned this to Jen or others yet, but we're hoping to have Nate and Tracy be able to come to the next MAC meeting. They've been trying to make their way around to various stakeholder groups, and where we have just recurring meetings, they are trying to get on the calendars of these meetings so that they can come and just become a little more familiar to the members of the MAC and talk a little bit more about kind of where we're at with consolidation and just their thoughts about what we're all trying to accomplish as our new Department of Health and Human Services. So the plan is tentatively that they'll be able to come and spend 15 or 20 minutes at the next MAC meeting. So it will be good to hear from them as well.
Thanks, Tanya. Stephanie.
Yeah, thank you for those updates. I think that could be exciting for a lot of the people that are receiving services, because I do think there's overlap in a lot of those areas. I'm curious what metrics y'all are looking at in the beginning to just like watch and see if those services do improve, and also like if you know the number of people that do have overlapping services between those departments that are now being brought together.
Yeah, Stephanie, thanks for those questions. I definitely don't have specific answers to those things today, but I mean, clearly, so much of the services that are funded by Medicaid have been delivered through entities within the Department of Human Services. So, for example, you could have an individual who is receiving just their regular state plan benefits, who may be a person with an intellectual disability, who has a co-occurring behavioral health or substance use disorder, and they may be receiving services from, what would have previously been Medicaid, and then also the Division of Services for People with Disabilities and the Division of Services for Substance Use and Mental Health. And so we know that there are many, many people who rely on services, a variety of services, and have the person receives services from multiple places within the agency. And we're definitely looking at where there are opportunities to do things better, to have things be more coordinated. One example that we've been talking about just anecdotally a little bit this week is, for people with intellectual disabilities who have co-occurring behavioral health conditions, that it really is hard sometimes to get them access to the needed behavioral health or substance use services that they need. And so, one of the things that we're looking at is, what are some specific actions we can take to help improve that access for people. And there is a process underway. think just part of the Department of Health and Human Services requirements are that we develop performance metrics, and the departments are in the process of working on those metrics. And I think those, I don't have the specific date, but maybe we'll take that down and have that as a question for Nate and Tracy to talk through on performance metrics, but those will be public facing items for discussion in the coming months.
Great, thank you, Tanya. Yeah, I look forward to that discussion. Thank you so much.
Sure.
Thank you. I have a couple other items in the time we have left I'd like to cover. One is a continuation of our consolidation efforts, is that we will, effective May 1st, be transitioning some of our branding and our currently used materials over to our new DHHS materials. So with this, you will see a release of our different brands and logos and our nomenclature that we'll be using. And so you'll see some of those changes after May 1st. We do have several months to transition the process, but effective May 1st, you'll see that in our signature lines, as well as meetings and different materials that we use for you. So a couple other items around our internal work. Many of you are well aware of our work we've done on our provider reimbursement information system, Medicaid, or PRISM system. Our broad system replacement that is going to replace our MMIS and MMCS systems. Our teams are highly engaged in the process of testing and training and developing all the materials that we need for this transition. With that, we have a broad communication plan that is also developed. It's drafted, and we're adding to that as we identify specific stakeholders and unique trainings that need to take place, as well as just general trainings. There is a Jeff website or webpage. There is a web location where this material will all be housed, and specifically for our provider groups, it's important that we are able to communicate when these trainings are happening. Some of them are on demand and some of them will be live. But this will have a broad impact on our teams internally, as well as our external stakeholders and our providers, as well as some of you who interact with our Medicaid system. So there is an enormous work being done on that right now, more coming to you as we are ready to bring it to the public front. I did also want to take a moment to introduce a new staff member. We have filled my position as the Office Director for Healthcare Policy and Authorization. And so I'd like to introduce Jim Stamos to you now. He's coming to us from Huntsman Mental Health Institute. And Jim, would you take just a moment? I'm sorry if I caught you here, but would you take just a moment to introduce yourself to the MAC committee members?
Hi, everyone. I'm happy to do it. I'm Jim Stamos, really happy to be here. I'm coming from University of Utah Health, and specifically been working at the Huntsman Mental Health Institute for the last 6 years in a management role there, and just really happy to be here.
Thanks, Jim. We're really excited to have Jim here and his expertise in behavioral health and systems management. He oversees a very large staff today and has transitioned that staff to telehealth through the pandemic, and has a good understanding of process improvement as well, and has implemented that in his work. So we're really excited to have him as part of our team. So welcome, Jim. Okay, and then last item I wanted to touch on was the work we're doing around several items coming out of the general session for 2022 this past year. If I could just touch on 3 items quickly. First, we are gathering House Bill 413, Representative Dunnigan, Medicaid amendments, which was looking at an integrated healthcare delivery model for TAM members. The item of this bill was looking at developing a working group that could help design this service delivery model. And we are have had a couple internal meetings just to kind of get a beginning framework in place. But we are working on identifying. The bill does outline specific individuals who do need to be included on this working group. We have drafted an introductory letter and expect that to be handed out pretty soon. We will begin and kick off our meetings of this working group in early May. Legislatively, we need to do it by the end of May, and we have our first meeting scheduled sometime early to mid-May, depending on people's availability and schedule. So more to come on that as we move forward with that work. The second piece is that the medically complex children's waiver had been funded to increase enrollment by, oh goodness, 120 individuals onto the medically complex. 130?
130.
Okay, my apologies. 130 new individuals to be enrolled in the medically complex children program. And there is work right now to hire 2 new case managers to support that expanded enrollment. So wanted to update on that. Third item wanted to update you on is medication therapy management. There had been some money put forth to support pharmacists conducting MTM encounters with identified Medicaid members who have chronic conditions. And the goal of this was to improve medication-related and health outcomes through these consults. And the work is being done now just to do the beginning policy work. We are going to be engaging external stakeholders in this within upcoming weeks to help design and define this policy. And I think that wraps up. One item on contracts. There is just the Motive Care contract, which is our very large logistic care, or they've gone by a new name called Motive Care now. That is our very large transportation contract, non-emergency medical transportation contract for individuals who are outside the UTA zone of transport. And there has been an RFP posted for that. It is still open, and we have been getting a lot of questions on the RFP, but it will close. The NEMT contract with Motive Care is extended through September, and so I believe when the RFP closes, we'll be evaluating for a vendor for that. So just those are updates from the director's office. I'll take any additional questions, or Jeff, I don't know if you had a CHIP outreach update you wanted to cover in that as well.
I don't have anything else to add, I don't think.
Okay.
Thank you.
Anything else? Thanks, Jesse.
Thanks. Actually, I did have a quick question. So, and I might have missed this when you were talking about the other items. Oh, and I see Destiny as actually, Destiny, why don't you go first, because I have many questions. The question is, who has access to view the unwinding dashboard?
This is Jeff. The answer is nobody except for Michael Keith right now. So no one does. Our hope is to get that launched as soon as we can. Again, as the baseline data starts to come together, we're getting the data behind that. Right now, today, it was very pretty, but that's not real data. I would expect that to be the web page to be launched when we get a 60-day notice. And very shortly after that, we'll be adding that data there. So it will be accessible to all at the same time. I can't even see it. It's only Michael Keith right now. You have to have a special invite. It's very hard though. But if there's a picture, if someone needs some of that data, we can certainly find a way to share that in advance if that's needed.
Okay, but it will be public. Sorry.
Oh no, go ahead.
Okay.
Yes, it will be public. It will be on a public webpage. So health.utah.gov/Medicaid, and I'm not sure what yet. So as soon as that webpage is announced, I'll let you know what it is.
Great, thank you.
You bet.
And will the unwinding plan be up on the website too, Jeff?
In the same magical place that's not yet there, but we'll have it as soon as we can. That was the one piece we had hoped to have by the meeting, but we just don't have it ready to go yet. I'm sorry.
Great. All right. Oh, Jen, actually, I just had one quick question in terms of additional provisions that might be extended. I know that did come up. I guess one thing I'm wondering about is non-emergency medical transport for the non-traditional Medicaid group. Do you know anything about that, or some of the other groups?
I do. So we have authorized through our MotiveCare contract the ability for the non-traditional population to receive transportation through this. Typically, MotiveCare is available to traditional Medicaid members, but we have opened the ability for non-trad members to get their COVID vaccines through the use of MotiveCare as well. It's been very, very low utilization of this as we've looked at the metrics. Almost nobody has used it, very low numbers, Jesse, but we have opened it up and have extended that through the PHE at least. So.
Great, thanks.
You're welcome.
Okay, terrific. Are there any other questions? Anything else? All right. Well, thank you, everybody, so much. I appreciate all the work and prep that went into this meeting and for the great conversation, and look forward to seeing everybody in May. So have a great month. Thank you all again so much for everything. Bye.
Thank you.